Leslie, you can hear me okay? Leslie?
We can hear you. Can you hear us?
Yeah, now, okay, good. Everything's fine again. All right, let me go back to the lecture. I just had to reset everything. All right, let's see where we left off. Nero, almost done. So let's get her done.
Excuse me, doctor. I had a
Yeah.
question about the diagram that you show us.
Yeah,
There's cranial nerve 3 on the diagram,
yeah.
and like how it's worked with the corticospinal tract. Like
No, it's just to show you that cranial 3 is in the midbrain. Remember, cranial
okay,
3 is at the top of the midbrain, so that's why I put it there. So for frame of
Okay.
reference, yeah.
okay, thank you, sir.
All right, so that's midbrain. We just did. Now increasing the cranial pressure. I'm going to take you through what happens whenever you have increased ICP. How does your body respond? By looking at the patient's exam, folks, you can tell exactly what's going on in their brain. So here we go. First sign. Remember, papilledema, swelling. Notice that answer has never changed. Never changed. It's been the same. First symptom, headache, because ICP is rising. Second sign, the first nerve to be compressed by increased ICP is cranial nerve 6. Cranial 6 runs right along the floor of the cavernous sinus. So any increase in ICP, you start pushing down the volume, the CSF pressure pushes on cranial 6 and paralyzes it. And that's why your eye starts to turn in. Remember, anytime you have strabismus, anytime after newborn, increasing the cranial pressure until ruled otherwise. So 6 is the first nerve to be compressed whenever ICP goes up, and your eye will turn in because lateral rectus is now paralyzed. So second sign, esotropia. Second symptom, you have blurry or double vision. Any questions? So first and second signs of increased ICP. All right, an attending will be impressed when you can tell them this. All right, first sign of herniation. That means when the pressure starts building high enough that you start to herniate. That means the top of the brain starts to come down. You crush the midbrain first. And right at the top of the midbrain, I just showed you cranial 3. So cranial 3 is the second nerve to be compressed. And therefore is the first sign of herniation, because all of a sudden you lose what they call, you get a sluggish pupillary reflex. See? That's why we're always checking the pupils when somebody comes in with increased ICP after a car accident, because you'll know that they're starting to herniate when all of a sudden the pupillary reflex is not brisk. If I shine a light in your eye, your pupils are constrict immediately. There's no lag to it. All right. So first sign of herniation, loss of pupillary reflex, and then you get anisocoria. That means one pupil now seems bigger than the other one. Remember, I told you anisocoria after newborn period, increasing the cranial pressure until ruled otherwise. And that's why, like that young lady I told you about, that's why everybody rushed to the ER and get a CT scan, because you don't want to sit there and you think, oh my gosh, she could be herniating. You can't just sit there and just say, well, yeah, probably no big deal. No, it is. Okay? Herniation. When you start herniating, you herniate down to cranial 3 and paralyzing. That means now, right beneath cranial 3, remember, red nucleus. That's why I showed you the picture. Red nucleus now is left to act alone. So here's the picture. See that? If you herniate down to here, 3 is out. So pupillary reflex gets sluggish and then blown pupil. Then after that, red nucleus is now active by itself because corticospinal cannot touch them. Everybody follow me so far? If you can't touch red nucleus will make the upper extremities flex because there's nobody controlling them. That's why they call it decorticate, as in the cortex is now gone. Decorticate posturing. The upper extremities will flex, lower extremities will extend. That's decorticate posturing. The second sign of herniation. So first sign of herniation, pupillary reflex is sluggish, all the way to anisocoria. Second sign of herniation, decorticate posturing. Any questions on that? That means you still got time, but you better be moving fast. Okay, what if you don't do anything? If herniation continues, there's a second sign, decorticate. And then if you herniate beyond the red nucleus, then upper and lower extremities are released and then they all extend. That's called decerebrate. Your patient's gone. Let's go through it one more time. All right, again, you gotta be, again, you gotta study it so you can look at this picture. Cranial 3 is right at the top of the midbrain, okay? Increase in cranial pressure. The first sign is based on cranial 6. All right, so sign is papilledema because that's swelling, first sign of everything. Symptom is headache. Then second sign, cranial 6 is compressed. Your eye automatically just turns in now. And the symptom, you got double vision or blurry vision because you got 2 visual fields now. Okay. First sign of herniation, the brain starts pushing downward and you crush cranial nerve 3. That's why your pupillary reflex gets sluggish and then boom, blown pupil. Okay. Herniation is just down to just above the red nucleus, but below cranial nerve 3. All right. Now, corticospinal and corticobulbar are compressed and lost. And then the second sign of herniation, red nucleus starts acting all on its own. It makes your upper extremities flex and lower extremities will continue to extend. We call that decorticate posturing. And then when you herniate beyond the red nucleus, all extremities will extend. We call that decerebrate posturing. Any questions on any of these levels? Again, it's in the vignette, and you just they'll just ask you what level of brain are we at? And this is how a doctor knows how far you got to go. That's if you know the clues. We had a case here in Champaign, and there was a young guy who got beat up at a bar, fighting over some girl. All right, not a wise thing to do, but they did it. So he got beat up pretty bad, showed up in the emergency room. They examined the kid. He seemed stable for a little while. Did a CT scan. They didn't think they didn't see any shifting. So they thought. The ER physician, his last note said, patient noted to be flexing his upper extremities and extending his lower extremities, discharge home. Remember I told you folks, it's only if you know what a clue is that you actually see it. He had no idea what that clue was. And of course, the guy herniated and died 4 hours later. Now, those are huge lawsuits and you can't defend it. Why? Because you wrote the note. You clearly don't know what was going on. All right, so you don't try to defend it when it's right there in documentation because they'll rip you apart on the witness stand and destroy your whole career. All right, but that was a huge lawsuit here. All right, now anytime I share stuff like that with you guys, I always do that as a learning process. I don't believe in laughing at anybody for making a mistake because that's hard to live with. When you realize you did something to kill somebody today, that makes you feel bad as a physician. Okay, but it just speaks to my point that most physicians, they've never been taught this stuff. They don't know the clues. They know a ton of stuff about diseases, but when you say, well, how do you know this one? All of a sudden they don't know because nobody taught them. You got to organize it. It's not about knowing everything. How do you know it's this one? How do you know this one? How do you know this one? It's like 2 or 3 words. That's it. That's why, again, I'm just giving you the highlights. This is how I know exactly where my patient is and I know what's going on. That way, when they ask me, I know exactly what's going to be compressed. Okay, Anders. Yeah, right above the red nucleus is decorticate, and right beneath the red nucleus, decerebrate. Correct. All right. So the final push is decerebrate posturing. The person is herniated. He's dead now. Nothing you can do to bring him back. All right. So this is the final stage of herniation. That's after the red nucleus. That means all extremities will extend because that's the default motion. Dorsal columns now. Pathways coming up. Dorsal columns have vibratory sensation, 2-point discrimination, position sense, and conscious proprioception. Vibratory sensation is when you do it a tuning for and they can feel it. Good. You put it on their toes. 2-point discrimination, you take 2 needles and or 2 toothpicks and poke their skin with 2 or 1, and they have to tell you when you actually did with 2. Only the dorsal column can carry that information. Position sense, you cover up their toes and you move it up or down. They have to tell you whether you moved it up or down. Only dorsal column can tell you that. And then conscious proprioception is when, let's say you ask them, or you could actually just observe the person. So let's say you have them walk like this. As they come close to something, immediately their body just goes to the side. That's conscious proprioception. Why? Because I can see I'm coming close to the podium. And automatically my body says move to the side. That's dorsal column. Okay? So when somebody keeps running into something, you're like, wait a minute. You didn't see that? Then that's how you know you got a dorsal column problem. Because you're not using conscious proprioception. You're seeing it, but you can't see to move out of the way. Dorsal column is out. Okay? Dorsal column is the only sensory pathway with 4 relays, but 3 synapses. First, we start off with fasciculus, and then we graduate up to tractus. Fasciculus, made up of a few fibers. There's no number to memorize. Tractus, a lot more fibers. No number to memorize there either. All right. Anything that ends in gracilis, graceful as a dancer, came from your legs. Anything that ends in cuneatus came from your arms. So you got fasciculus, gracilis, then tractus, gracilis. Fasciculus, cuneatus, then tractus, cuneatus. That's it. All right. So leg fibers are medial, arm fibers are lateral. First relaxation for everybody is dorsal ganglion. This is for all information coming up to the brain. You have to stop at dorsal ganglion because that's where you have those interneurons that allow you to send the information down to your legs in case your legs need to make you do something like jump out of the way of a car. Way before your brain even registers information, you're jumping. That's because the signal goes down to your leg because your brain says, hey, get out of the way. Or there's a dog coming, start running. Before your brain even got the message, you're running. Okay? That's why you got to stop at dorsal ganglion, but it does not synapse with it. So it's not a synapse, it's a relay station. Okay? Then it forms a fasciculus, then the tractus, so gracilis and cuneatus. The first real synapse, that means the first time it actually stops, is at the nucleus gracilis and nucleus cuneatus in the medulla. Remember, gracilis is medial, cuneatus is lateral. Second synapse, where does all sensory information go to, Solange? No, we're in the medulla now. Nucleus gracilis, nucleus cuneatus. All sensory information going up must stop where? There's one more place. All the messages stop where? Thalamus. That's where we're going next. Second real synapse, thalamus. VPL, VPM. All right, same thing. M for legs, L for lateral. That's your arms. And then the third and last synapse is when it goes to parietal lobes and stores information there for you. This is why if you had to jump out of the way of a car, guess what? The next time a car starts coming, you jump a lot faster because the information is already recorded in the parietal lobe. You know it's dangerous to be in front of a car. Or you touch a stove and you pull away. Next time you even come near a stove, you pull away before you even touch it now. That's this pathway. Okay? All right. That's dorsal column. Any question on dorsal column? All right. Dorsal column pathology, syphilis, we've talked about. When you have syphilis, vasculitis, what vessels are being attacked? Mayha. The vessels being attacked in the aorta. Montessori, vasovasorum. Remember, tree bark appearance. Vitamin B12, we already rehearsed it a few times, so we're not going to do that again. But bronze succar is when somebody gets stabbed in the back and the knife just slices through half their spinal cord. How do you know you got bronze succar? Everything is lost on the same side from that level down, except corticospinal tract, pain and temperature, which is on the opposite side. So for that reason, folks, I use that to know a spinal cord lesion. Now remember, I know it's a brain lesion when upper motor neurons are entire side of the body. You're on the opposite side of the brain. If you tell me pain and temperature is opposite to every other deficit, you're telling me it's a spinal cord lesion. Because pain and temperature are the only ones who cross the spinal cord. Everybody follow that? This again, because once you say it's a spinal cord lesion, you can scratch out the answers that talk about the brain. That eliminates 2 or 3 of them. Okay, now it's just a matter of what level do you want the spinal cord lesion? And I'll show you in a second. So dorsal column pathology. Spinal thalamic tract, pain and temperature fibers. This is the only path that crosses in the spinal cord. And the place they cross, remember the central cord, also known as the anterior white commissure. Fibers enter the spinal cord, they go up 2 levels and then cross. So here they come. They come in, they go up 2 levels, and then they cross. They come in, they go up 2 levels, and then they cross. So that means if I'm a fiber coming in here at T8, where am I going to cross, Jess? What level am I going to cross? All right, when fibers come in, they got to go up 2 levels and then cross. So if they come in at T8, where are they crossing? T6. Now, I asked you that question because I can tell you zoned out. But anyway, the other reason is when I say go up, Students make the mistake, T8, and they pick T10. T10 is going down. Easy, a mental error. Gotta be careful, okay? Or if they go the opposite way, let's say you got a tumor at T6, you don't get any losses till T8. See, they like to ask it that way as well. If you got a tumor, epidural abscess at this level, where's the loss going to begin? And you got to know it's going to be 2 levels down and it crosses the other side. That's pain and temperature loss. Any questions? So spinothalamic tract helps me to figure out spinal cord lesion. Everybody understand what I'm saying? Anytime pain and temperature is opposite to every other deficit, you are definitely in the spinal cord. There's no way a test writer can change that. But that's why you got to know it. That way you don't start reading answers about the brain. I don't even want to read them because you're taking a chance. If you read them, you're planting a thought in your head. It should not be there. Okay? All right, so spinothalamic tract. First relay station, dorsal ganglia, just like everybody else. First real synapse, thalamus. Second real synapse, parietal lobes. Again, all your long-term memory stored in the parietal lobes. Spinothalamic tract pathology, remember syringomyelia. We've talked about that, along with meningomyelocele, along with arnochirary malformations. So spinothalamic tract pathology. Spinocerebellar, last pathway. Spinocerebellar pathway. This is the only pathway in the spinal cord that actually crosses twice. I learned this the hard way. Because if you're on the left and you cross to the right and you go back to the left, aren't you still on the same side? And that's why the books always say they're on the same side. But they never told you that's not really true. It just crosses twice. Till I saw a question that said, which pathway crosses twice? I had no clue who they were talking about. That's how I learned it. This is what I mean by a lot of incorrect information is written in the books because the author just thought it was just easier to just say it that way. Okay, but you got to know better. All right. All right. Spinocerebellar, the most unique information, depth perception. Know how far out things are. It develops by 6 months of age and stays for life. Depth perception. Signs of damage. Look at this, intention tremor. Nothing at rest. When I say grab that cup, all of a sudden now you got to figure out how far out that cup is. You can't do it. All of a sudden they knock it down. That's an intention tremor. Only the cerebellum can give you that problem. Dysmetria, finger in the nose. Pronator drift. When you put your arms out like that, all of a sudden without thinking about it, the arm goes down. That's because they can't tell what's going on way out there. That's depth perception. Dysdiadochokinesis, rapid alternating with their hand. If you say do it, they can't do it. So when they do it, concentrate real hard on one side, do that a few times, then they turn around and do, no person doesn't have to do that. Dysdiadochokinesis. And then Romberg sign. You have them close their eyes. See, now it's not conscious perception because their eyes are closed. And once you close your eyes, you actually will notice your body is swaying in the air. You just don't know that when your eyes are open because your body adjusts everything. Now you realize, oh, I'm swaying in the air. And then within a few seconds, the person will overcorrect and lunge to one side. That's why they always say, put your hand on their side like this. As soon as they lunge, it hits your hand, positive Romberg side. Okay? Spinocerebellar pathway. Oops, going the wrong way here. This pathway does not reach the cortex. That's why they call it unconscious proprioception. Does not reach the cortex. So if they ask you what pathway never reaches the cortex, is the one. As soon as it comes to the spinal cord, it turns right and left and reaches the cerebellum on both sides, but it never goes beyond that. Rachel? Yeah, I'm not sure why it says that, but it's supposed to be, they cross twice. It crossed twice. So that means the editor probably got that out of the book. I told you the book says it one way, but that's just out of convenience to doctors. Oh, it just stays on one side. No, it does not. It crosses twice. Like I said, I had to learn the hard way when I missed a question and then I looked it up in the book and it definitely did cross twice, but I had never seen that before. All right. So the pathway does not reach your cortex. That's very important, folks. It stops at the cerebellum. First relay station, dorsal ganglia, like everybody else. First real synapse, thalamus, like everybody else. Second real synapse, the cerebellum. It never hits the cortex. Spinocerebellar diseases, alcohol is the one they're always going to ask about. Remember, we talk about alcohol a lot in biochemistry. And they're gonna ask it again in neuro. Alcoholics. All right, alcohol attacks the vermis, which is the midline. So as soon as they say midline, I know it's alcohol they're talking about. Because every other disease attacks the hemispheres. That means laterally. Okay. How do you know alcoholic withdrawal? Ida. Formication. What's the best benzodiazepine for alcohol withdrawal seizures? Gloria. Which one? I mean, you could use lorazepam if they got liver disease, but that's not the best answer for. Yeah, no, not diazepam. That's only if this other drug is not on the list. Remember, chlordiazepoxide is the best one. Yeah. All right, Friedreich's ataxia we talked about. Give me one thing that goes with Friedreich's ataxia. Sandra. High incidence of something. What? Scoliosis, retinitis pigmentosa, and hokum. Friedreich's ataxia. Ataxia telangiectasia. I'm giving you a ton of clues for that one. Mitchell. Yeah, remember, yeah, spider veins all over their body. Telangiectasia, 95% of them have it. I give you IgA deficiency. Right? I gave you malabsorption, so it should have been GI. Malabsorption is what leads to demyelination of the cerebellum, which is how they get ataxia. So here it is again in neuro. It has to do with DNA breakage repair from free radicals. So it was in DNA and RNA chapter. So this guy I told you is like in 6 chapters. You gotta definitely make sure you know him. Adrenoleukodystrophy, CAT1. Carnitine acetyltransferase is for transporting Vitamundo. Is it for long, short, or medium chain triglyceride? Carnitine. No, CAT1 and carnitine. Is it for transporting short, medium, or long chain fatty acids? Remember, only long chain. There's no short and long. Short and medium go through with no problem. It's only the long that need CAT1, right? Austin, you understand? Avi, you understand? So CAT1 is one of the 10 X-intercept enzymes, right, Ida? Well, if there's only one, that means there's 9 more out there. Oh, Karis, don't be tightening up like that now. You know, that's what gets you called if you start doing that. All right, let's go to Nolan first, though. Give me 3. G6PD, LASH9 HGPRT, SCID. 2/3 of cases, IL-2, IL-7 receptor defect. Bailey, give me 3. OTC, Fabry's after galactosidase. Now here's the Hunter's hydrogenase. So up to 6. This is number 7. I need 3 more. Ida, finish it up. If you say it, I'll tell you. Keep going until I hear a new one. Aha, PRPV synthetase, that's 8. Adenosine damage already got said. CGD. CGD, NADPH oxidase, that's 9, only 1 left. Gloria wants to help you out. Huh? Yeah, tyrosine kinase. All right, so you got it. Very good. Make sure you know the 10. Remember our golf patch. Is that the one? Yeah. All right, PONS, responsible for responding to the environment. Contains the pneumotactic and apneutic center. Pneumotactic makes you exhale. Apneutic makes you breathe in. So pneumotactic and PONS make you breathe faster or slower depending on what environment you're dealing with. That's why you breathe faster when you're scared or slower when you're relaxed, that kind of thing. So the PONS responds to your environment for you. All right. The PONS is the CNS area most sensitive to osmotic shifts. And that's why, Leslie, you should never let your sodium change any faster than what number?
0.5 per hour.
Yeah, 0.5 milliequivalents per hour or 10 to 12 milliequivalents per day. And don't let glucose change any faster than what number? Leslie.
I don't remember that one.
No problem. Brenda Rivera.
100.
Yeah, 100
Per
milligrams
hour.
per hour. Yeah, the PONS, remember central pontine demyelolysis. So those root ganglion diseases, 3 of them. Polio. Polio is a low motor neuron disease. you get gastroenteritis and then asymmetrical paralysis. Remember, we talked about this in neuromuscular diseases. All right, but it hides in dorsal ganglion. That's why they like to ask about it. And then comes out whatever nerve root it feels like coming out. Varicella zoster is old chickenpox. It also hides in dorsal ganglion and then comes out on any dermatomes it feels like. The top two dermatomes, however, T4, the chest, level of your nipple, and then V1, forehead. Top two places for zoster outbreak. Rabies attack starts in dorsal ganglion and then goes up to the medulla and attack all the ganglion. And that's why all of a sudden, when you attack cranium 9 and 10 in the medulla, they start doing that. And that's why they hate to drink water, because if you do that, you have to close off your trachea and they can suffocate and die. So rabies, 3 dorsal ganglion diseases. So what we've done, folks, is gone from the top, come all the way to the bottom. Pons pathology, locked-in syndrome. Okay, central pontic pneumolysis. Both of those, you lose all ability to respond to the environment. Medulla controls all your basic functions, including breathing. Make sure you know your cranial nerves. There's always a 1 or 2 questions where they just ask, what cranial nerve is this? I remember on my exam, they said, which one is cranial 7? So, oh, that's good. All right, again, all these sexual mnemonics, just make sure you have one. Okay, I'm not gonna repeat them, just make sure you know one. That way you know all 12 cranial nerves. Then you gotta know where they're sensory, motor, or both. All right, so some say marry money, but my brother says big boobs matter most. You guys know that one? Okay, well then know it, because they will ask you about a nerve. So I remember on my test, they said which one of the nerves has afferent sensory and efferent motor. I'm like, hell, I never heard about that before. Then I said, oh, sensory and motor. And I just went down my fingers and only one of those nerves was there that does both. See, this one always finds a real sneaky way to ask you the same old stuff. Okay, rather than just saying, oh, which nerve is sensory and motor? He calls it visceral, afferent, sensory. It just sounds complex now. All I did, sensory and motor. Oh, I know which one he wants. Okay, so make sure you know that. And then look at this. Whenever you decide it's a brain lesion, listen carefully. Whenever you decide it's a brain lesion, can you hear me real well, Mabel?
Sir, yes.
All right, Mabel, listen carefully to this one. All right, whenever you decide it's a brain lesion, I use the cranial nerves to tell where the lesion is located in the brain. And so does the test writer. So if I know you take the 12 cranial nerves, divide them into 3 groups of 4. But remember, 1 and 2 are outside your brain. They're not inside the brain. So that means you start out with 3 and 4 in the midbrain, 5 through 8 in the pons, 9 through 12 in the medulla. And then put them in this same order, lateral to medium. Let's say, for instance, if they ask you about lateral medullary syndrome, Waldenberg syndrome. If you look up lateral medullary syndrome, cranial 9 and 10 are the ones that are knocked out. Now, I say this because I know students are arguing, oh, but the book said, I know what the book said. The book is real precise about where all the ganglia are located, but I found that if I just look at it this way, it answers almost every question about where the lesions are at. Let me show you what I mean. Here we go. Somebody got into a car accident, got hit in the head, comes in, and they say, boy, he's having trouble shrugging his shoulder. You say, okay, 11 is out. And then they say, okay, he has trouble hearing. I said, oh, 8 is out. Then they say, oh, he has a blown pupil. I said, oh, hell, 3 is out too. All you do is put the lesion right here at the midbrain level. That means all these other ones got clipped on the way up to the cortex. See that? In and out in less than 5 seconds. And you're going to see a whole lot of stroke patients where they're going to ask you what a lesion is. Folks, be organized. If you want to impress a neurologist, use this pad. I'm telling you, it used to blow them away. Okay, because, oh, so I got to tell you one story to end our lecture for this, right? I had one patient, this was with Dr. Rick. We went to see this patient. 4 specialists have been on this case. This guy came in, he was comatose. And he was bringing fevers, just fevers, several times a day. So they called infectious disease. He said, well, he's got fevers. He's in a coma. I don't know where these fevers are coming from. But he started antibiotics, and let's hope we can clear it up. Okay, fine. Then all of a sudden, his kidney shut down. from hypotension. So what they do, they call in the nephrologist. The nephrologist says, okay, fine, I'll follow along and take over his electrolytes for you. But I don't know where these fevers coming from. I don't know where this man is comatose. Then the guy started having arrhythmias, and they call it cardiologist. Cardiologist said, yep, he's having arrhythmias, all right. I'm gonna start him on this medication. But I don't know where the fevers are coming from. I have no idea why this man's in a coma. So they call a neurologist. The neurologist took a look at him, and he said, I have no idea why this man's in a coma, and I don't know why he's got fevers either. So anyway, so we got consulted in internal medicine to follow along. And Dr. Rick said, no, let's go see the patient for ourselves. He said, I don't believe in just believing a bunch of specialists talking. I want to see the patient myself. So we went up there. So me, I think 2 or 3 other residents. So they got to examine the patient first. I was the last one. So I examined the patient. I remember the last thing I did was this neuro exam. I checked the right, well, let me see, I was on his left. So it's the left knee and brisk reflex. And then I did the right knee, thump barely went up. So, huh? So let me try that again. I did the left knee, no problem. Did the right knee, barely went up. I said, oh, what dermatoma is that, man? Dermatome for the knee, That's why I just told you it was knee. His knee is where the reflex is dull. All right, you forgot everything. I just give you guys all the numbers. Anders, L3, L4. So he let all the other residents speak, and he said, Franz, what do you think it is? I said, Dr. Rick, I couldn't tell you what it was, but I can tell you where it's sitting. He said, what do you mean? I tell you, it's sitting at L4. I said, with your permission, let me order a stat MRI. So we had teaching rounds for 2 hours. I said, let me order a stat MRI and ask the neurologist, the radiologist to call us with the results right away. So he said, okay, fine, let's do it. So order a stat MRI, and we were down in the teaching room for about 20 minutes. And then we got this phone call, and I could hear in the background, somebody said, damn, who figured this out? And Dr. Rick said, well, Dr. Francis, he said, the guy had an epidural abscess sitting at L3, L4. That's why he was having fevers. And he had hypotension because he was in septic shock, which means low flow to his kidney. Kidney's the first one taken out, renal failure. And then ischemia to the heart, that's why he had arrhythmias. And ischemia to the brain, that's why he was in a coma. Man, y'all better leave me alone, boy. Eh? See, most of all these specialists, but they didn't know. Brain, heart, kidney. No, it's got to start somewhere else. The kidney was the first one taken out. And the heart, then the brain. That's exactly what went on in this guy, but the other guys didn't figure it out. That's why, again, if you're organized, and that's one thing Dr. Shah just changed my whole life. By being organized, I don't have to be a neurologist, but this scheme was so good that I can walk into a room in just a few minutes, I can tell you exactly where that lesion is, just by looking for which cranial nerves are involved. And when I do a question, I just pay attention to the cranial nerves. That's it. Once they say hemiplegia, okay, I said brain lesion. And then I look at cranial nerves, I know where the lesion is. Now you know midbrain, pons, medulla. Now it's an easy question, and you're in and out in no time flying. Any questions on this? Yes.
Yeah, I have questions.
All right. Wait a minute. Oh, sorry. Mabel was first. All right, Mabel, go ahead.
So
What's your
please, based on what you explained to us now, are you saying that the lesion is at the medulla?
What lesions at the medulla?
Because you were saying that it has an eye vision, whatever, then the 3 is out, pon is out.
Yeah, I said,
So-
but he has trouble shrugging his shoulder. That's 11. He has trouble hearing. That's 8. And his pupil is blown. That's 3. You put it in the highest location of the brain, and that would be midbrain. That way, the other nerves got clipped on their way up to the cortex. Because remember, the nerves travel upward. So you can't put it in medulla. If you put it in medulla, it don't affect cranial nerve 8. It doesn't affect cranial nerve 3. You're just leaving those alone. You can't do that.
Okay.
Yeah. All right. Who was talking? Lauren, go ahead. That was your question? Yeah. All of a sudden, folks, it made it easier to figure out lesions. Because before I was trying to figure out, put something here, but I didn't know. All you gotta do is, because the fibers travel upward, just put it in the highest location. All the other fibers got clipped on the way up. Real simple. Real simple. Like the lateral medullary, see, which is pica syndrome. See that? 9 and 10 are always clipped in pica. I said, oh my God, it works. And so I've tested all these years and it works. Oh, it doesn't follow the exact book where the ganglia are located. I already know that part, but this works for lesions, folks. It really does. All right, folks. There it is. You've been empowered. All right. All right, take a 10-minute break, and then I'm gonna introduce you to pulmonary, and then we'll finish up on Monday.
Oh, when are we finishing for today?
We finish at 12, Mabel. We haven't gotten to 12 o'clock yet. We're only go for about 20 more minutes. So we're gonna take a 10-minute break. Go ahead, take a break, folks. And then I'm gonna start pulmonary. I just want to introduce you to it. That way, I just gotta cruise right through it on Monday. And your question.
So the spinocerebellar tract,
Yes.
I thought it stops at the cerebellum.
Nobody can hear them all. They're up this one.
Mabel, you want to hear our discussions too?
Yes,
Okay, that's fine. All right, what's your question?
I have a question too.
No questions. We start back in 5 minutes. I go ahead.
Considered an adverse side effect.
Yeah, it's an adverse side effect till they realize they can use it to treat a problem.
Yes.
Yeah.
Side effect.
Mhm.
not treatment.
Yeah, it's the same way we use thiazides to cause to
that's
treat nephrogynic DI. It was initially a side effect. You get SIDH with that thiazide. But if you got nephrogynic DI, they can use that side effect to treat the problem. Yeah.
Other question was the polyhydramnios.
Polyhydramnios.
So you said 80% is, I mean, okay. it's
80% of the amniotic fluid came from mom, but she started out by
Sorry.
donating 90. The baby swallows 10, right?
Does.
Right.
10 cells,
Mhm. That's correct.
Polyhydramnios is not drinking, so treat.
Yeah, he's not drinking. So that means that mom's extra 10% starts piling up now. That's how you get poly. Yeah.
But then, wait, that's not. But then I thought that, so you go to diabetes, the mom, the baby's eating a lot and that's adding to the poly.
No, you're saying how does diabetes cause poly? Yeah, he has to swallow 10 and then pee out 20 because he had his own 10 to the 10 he drank. Yeah, with in poly, if the baby cannot drink, that means he's still peeing, but he's not swallowing away mom's 10%. That means that 10% starts piling up now.
You can pee without swallowing.
Yeah, you can pee without swallowing.
How did he do the pee?
Bloodstream. The pee is a filtrate of his plasma. No, he's still peeing out 20. It's just that he's not taking in the 10 that he should have taken in from mom. He's still peeing out 20. Yeah. And that's why it starts to pile up. All right.
Excuse me, Dr. Francis.
Yes.
Excuse,
Leslie.
sir.
We have a question like at the end of the neuro presentation.
Okay,
there's
what's
some-
your question?
There's some slides about seizures. Like
Yeah.
that
no.
part we have to discuss like by ourselves.
No. You can remember we've drilled the seizures twice.
Okay.
I'll go through it on Monday. Look it over the weekend. We've drilled seizures a couple of times. It just goes over the drugs of choice. But there's one point I want to go over, which is epilepsy. And I'll do that on Monday.
Okay, thank you, sir.
But definitely go over treatment of choice, because that's the number one thing. Remember, they're gonna ask you what a seizure is, and then what's the generalized seizure, and then the different types of seizures, the management. That's the main thing, but I want to go over what epilepsy really is, and I'll go through that on Monday.
Thank you,
Yeah.
sir.
No problem.
Excuse me, sir.
Yes, Mabel,
Please,
go
sir,
ahead.
what would they ask me? Then I will use golf patch as and start asking the question. What would they ask? Then I will use golf patch to start asking my question.
That's the 10 enzyme deficiencies that are X-linked recessive.
Oh,
Yes, ma'am. All right, remember we've
it-
drilled that
X-linked.
thing, we've drilled that like 3, 4, 5 times already. So
Okay,
again, make sure you go
X-linked-
through it. X-linked
this-
recessive
this-
enzyme deficiencies.
okay. X-link and is that okay?
Yeah, because remember, 99% of enzymes are autosomal recessive. Make sure you know that, Mabel.
X-link and what?
99% of enzyme deficiencies are autosomal recessive, Mabel. Make sure you know that. Take a break. All right, let's go through some pulmonary. I just want to set it up, then we'll finish out Monday morning. The stuff in the back of neuro for seizures, even though we've drilled it a couple of times, we'll go through it one more time on Monday afternoon, okay? But make sure you go through the notes. Because all the stuff you've heard me drill in class. But I just want to go through in case anybody has any question on why it's that way. All right, here we go. Pulmonary physiology, just like everything else. The lungs develop in the first trimester. After the brain, heart, and kidneys, so they're always first. The lungs come after that. All right, foregut endoderm gives rise to respiratory tract, as well as GI tract from the mouth to the second part of duodenum. Remember, you saw this in GI. That's why I want to go through some of this, because some of this in the beginning is repetition, stuff you've already heard before. Neurocrest is a group of cells you need to understand. Neurocrest, first of all, what does it mean? It means you were born in the CNS. Where's the CNS, Michael? These are cells that are born in the CNS. Where's the CNS? No, where is it? What is it? What makes up the CNS? Brain and spinal cord. So these cells were born in brain and spinal cord and then migrated out to the periphery and then stayed there. That's why so many of them can produce neurotransmitters. They're supposed to be in the brain, but they migrate outward. Okay. Motel Pass was a nice mnemonic a student came up with years ago, and it works. Okay, update is that parafollicular cells are now found to be not neurocrest, they're mesoderm. All right, and then the other one, the one that they like to ask about all the time, adrenomedulla. Da, 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 da. Why the adrenomedulla? Because adrenomedulla is the only ganglion who doesn't have the word ganglion in his name. And they know the students are going to forget. See? But adrenomedulla is a ganglion. And as such, what neurotransmitter will stimulate a ganglion, Gloria? It's called acetylcholine. A lot of students end up picking norepinephrine without thinking. That's what it releases. The question was, what stimulates it? See? They start thinking of adrenomedulla. Oh, norepinephrine, epinephrine, but that's not what they asked. They said, what stimulates it? Acetylcholine stimulates every ganglion, no exceptions. Okay? So neurocrest, make sure you know Motel Pass because they love it. Embryogenesis develops in the first trimester like every other organ. But then surfactant production is not complete until 32 to 34 weeks. So be careful, therefore, when does the organ develop? 12 weeks. But when is surfactant developed? Not till 32 to 34 weeks. That means that lung cannot work until then. So for that reason, Carriage, you don't want any blood to go to the lungs. So we shunt it away from the lungs using what vessel? Blood that was headed for the lung, we shunt it back to the aorta using the PDA. That's how I remember in utero, the PDA, remember, it's a right to left shunt. Once you get born, take a couple of breaths, it's a left to right shunt now. Okay? So PDA shunts blood away from the lungs because there's no oxygen in there. Without any oxygen, what's happening? High resistance. That's why you shunt everything away. Okay? All right. Notochord, we just saw from neuro, visible by 3 weeks, brain formed by 8 weeks. Surfactant, his main job, to decrease atmospheric pressure's effect on the alveoli. In other words, it prevents them from collapsing. It prevents this word called atelectasis, which means collapse of the alveoli. How do I know you had atelectasis? It's because when you breathe in, I hear crackles. Remember, I've told you several times. Anytime a patient has crackles, it means they have atelectasis. That means the alveoli actually were allowed to collapse. That means where does surfactant go? That's why I said number one cause, fluid washed it away. Now that fluid can be from heart failure, pneumonia, bronchitis, bronchiolitis, a million things. But that's the way I want you to interpret it. I need something with fluid in the lungs followed by something with fibrosis in the lungs. All right. The second thing surfactant must do for you, increase compliance of the alveoli. That means ease of distension. It's like an oil slick on top of a balloon. If I say grab this balloon and it's got oil on it, every time you try to grab it, it slips right out of your hand. So notice atmospheric pressure then is always trying to grab your balloons in your lungs and collapse them. Well, what if I put an oil slick on top so it cannot grab it very well? Zip, it keeps sliding off to the side. And that's why your alveoli in your lungs stay open all the time. Any questions on the function of surfactant? I want you to be able to visualize it. Two things that surfactant must do for you. Compliance, that word is change in volume over change in pressure. What happens to your compliance as you age, Mabel?
Sure.
I said, what happens to your compliance as you age, Mabel?
Okay, the compliance, I think is decreases.
The compliance of your entire body decreases. All right? The compliance of the lung actually increases, but the chest wall decreases. So watch out for that. They caught me a long time ago with that one. You know, that's why they call it senile emphysema, just aging. Your lung inflates, but your chest wall is stiff. So the lung compliance increases, but the chest wall compliance decreases. Because that's, you're talking about bones, you know, arthritis. Can't help that. Yeah, it's because of elastase. Over time, you don't have enough alpha antitrypsin to block it anymore. And that's how you get the emphysema, but the chest wall is still stiff. Okay? All right, that's surfactant. Lecithin and sphingomyelin. Lecithin, you've learned in two places. Number one, in the GI tract to help you absorb your fats. Remember, emulsification of fats was a term that they used. And the sphingomyelin is used to myelinate your nerves. Early on, Mitchell, which one do you think is more important? Yes, sphingomyelin. And that's why LS ratio is low early on, because your denominator is a bigger number. Does everybody understand that? So you don't just quote LS ratio is low, but you don't know what that means. It's because you're myelinating the brain. That's more important. Way before you start doing anything in the GI tract. And then if you modify lecithin a little bit, now you call it surfactant. So lecithin is needed in two places, right? Maybe that's why they always talk about LS ratio of 2 to 1 or greater. See, they didn't just choose 2 out of the blue, folks. There was a reason, because lecithin is needed for 2 different things: emulsify your fats and used to make surfactant. But sphingomyelination must come first. All right. You know that surfactant production is complete when what? When lecithin sphingomyelin ratio is 2 to 1 or greater, which means your body is actually paying attention to the other two places now, GI and lungs. That means it must be done myelinating. Okay. Or you detect a breakdown product of surfactant called phosphatidylglycerol. So either one tells me your lung is now ready for the outside world. If mom comes into labor with preterm labor, you say, oh boy, if it's before 32 to 34 weeks, I am concerned. Is this baby's lungs ready for the outside world? That's why we check an LS ratio right away. Remember, the question will be, what's the next step of your management? You're supposed to know that's your main concern right now. Any mother comes in labor before 32 weeks, I am concerned if this baby's lungs are ready for the outside world. Because you don't want to deliver that baby, his lungs will collapse as soon as you pull him out. And now you realize his lungs are not ready? You don't have a tube, you don't have an oxygen tank, you don't have a ventilator. The kid will be brain dead in no time flat, or have severe damage that's gonna be blamed on you. And you don't want that. That's why we check an LS ratio, and that's why we check phosphatidylglycerol. If either one is positive, then at least the baby is okay to come on out. If either one is negative, then you need to do something about it. We need to stimulate this baby to make a bunch of surfactant very quickly. Anam, you have a question?
Yes, sir. What is the management if it's a premature baby? Because they're not going to be able to, less than 32 weeks down there.
Yeah, don't worry, you're getting ahead of me. It's coming up.
Okay,
So the
good.
question is, the first thing you do when they come in premature, the first management is check LS ratio, check phosphatidylglycerol. That's the first thing you're supposed to do. If the both of those are negative, it means you need to stimulate surfactant production. How do you do that? Stress the baby out. What's the number one stress hormone in your body, Anam?
Cortisol?
Cortisol. All steroids are a form of cortisol. So we give them a steroid. Which steroid crosses the blood-brain barrier fastest? Anam.
Is it hydrocortisone?
No, not hydrocortisone. Let me ask Jess. Which steroid crosses the blood-brain barrier fastest? Let me ask Leslie.
Indomethacin?
No, endomethacin is not a steroid. I'm asking for the steroid that crosses the blood-brain barrier fastest. Ashley. Are you asking me or are you answering my question? Then say it is dexamethasone.
Oh,
Thank you very much. Why do you think it's right here in front of you? So IM dexamethasone is not a preferred drug. Just so you guys know, they didn't just pick these things randomly. When you're memorizing, it looks random. It is not. Somebody has to understand physio and biochem to make these choices. Because we used to use Becla and betamethasone. So somebody said, why are we using this stuff when this one crosses faster? Of course, when they did a study, better. But notice, somebody has to say, wait a minute, how come all these experts are using this other stuff? And as physicians, we just memorize whatever the book says and just keep using it. Okay? But again, that's why I'm telling you, with Dr. Shah, after him, man, I would question everything. Anytime I see someone say, why is that one? I told you, always ask yourself why and how. If you want to do the best for your patient, ask why and how all the time. All right, anyway, IM dexamethasone is not a preferred drug to induce surfactant. Why? Because it gets across the placenta real fast and it makes the baby feel instantly that he's stressed because cortisol levels go up. And if you're stressed out, what's the first discharge coming out of your brain, Michael? Parasympathetic. Look it up. Parasympathetic to your lungs is increased surfactant production. Isn't that amazing whoever thought that up? How can we fool the brain into thinking, hey, just put out a lot of parasympathetic so you get tons of surfactant. That means you get surfactant production in just a few hours that it would have taken weeks for a baby to make. But it worked. Okay, it worked. If the baby is still born early, that means before this thing works out, has actually had time to work, we now have synthetic surfactant. See, that's how you manage premature baby. Any questions so far? Now, between 32 and 34 weeks, that's when surfactant is made, right? So if the baby is between 32 and 34 weeks, you still check these levels just to make sure everything's fine, okay? But then you want to buy time. So you want to stop the labor. Adam, what tocolytic can you use?
Terbutaline?
Yeah, you can use terbutaline. You can use even nifedipine, muscle relaxant. Remember calcium channel blocker? And it works. Let me slow down the peristalsis, slow down labor. I want this baby to stay in here as long as he can. Okay? So whenever they come in around 32, 34 weeks, now you have other things you have to consider. Let's stop this tocolysis. Stop the labor. Okay? So nifedipine or terbutaline are the two that are being used. Then you give him magnesium sulfate. Why is that? Remember, neuroprotective. We just did neuro. Magnesium is a cofactor for all your kinases. That means you're going to generate a lot of ATP for the brain to finish forming. And that's how it makes sense to me. Any questions so far? Again, this is all the management. So we did before 32 weeks. Now we're doing 32 to 34 weeks. Okay. And if mom has unknown GBS, that means she was never screened or she was positive for GBS at any time during a UTI, during her screen, or in a previous pregnancy even, you need to give penicillin when they come in labor and give penicillin to the baby when he's born. That means you got to do septic workup to protect the baby because you don't want the baby infected. Remember, blood-brain barrier is wide open, wide open. That's why they came up with those strategies. You follow me, Adam?
Yes, sir. I was actually
All right.
connecting that.
Leslie,
unknown
you
is
understand so
positive, right?
far? Because this is on
Yes.
your exam as well. Very good.
yes, doctor, thank you.
Yeah, yeah. And then if the baby's born at 35 weeks, notice it's closer to term, right? Then you don't want to use tocolysis. Let the baby come on out. Yes. No, you produce a lot of, so he's asking me if you use parasympathetic discharge with dexamethasone, doesn't it clog up the bronchioles? Yes, it causes some bronchospasm. That's normal parasympathetic, but you get tons of surfactant, which is what we want. So the benefits outweigh the side effects because these babies live longer now. Whereas before they had such severe lung disease, good Lord, 6 out of 10 would die. Okay. All right. So after 35 weeks, again, you don't have to do tocolysis because that baby's mature and ready to come on out. And then what was the one more thing? Oh, and then with the penicillin for the GBS, because the baby's more than 35 weeks, they say you can just observe the child. You don't have to do a septic work and give them the antibiotic. So before 32, 33, 34, and after 35 is what I just reviewed for you. How to manage a baby. All right. Now, again, I try to make sense of this information, folks. Otherwise, how do I remember this if I just memorize a bunch of lists out of somebody's article and then try to teach it in front of a class? I'm going to forget half the stuff. Okay. But each one, every time they come over, oh, that makes sense. Okay. I see it now. And so I can visualize, why did we come up with these 4 things you need to know? It makes sense to me. And that's why I'm showing you how I make sense. So you find a way to make sense of it. Don't just memorize it because I said it. Because then I'm afraid you're going to forget it in a few days. Now you don't know how to manage it again. Okay. That means we're right back to 0 again. All right. So this is mom coming with preterm. All right. Let's just do this pattern here. When there was no surfactant, this is before they discovered surfactant. I remember my hospital was one of the study sites for this study. All right. When there was no surfactant, as soon as the baby was born, Amy, alveoli would collapse. You now have atelectasis. You understand? If you have atelectasis, that leads to very poor compliance because that means it's not going to inflate so easily. You with me? If you have very poor compliance, that's going to increase the work of breathing. That baby's going to struggle to breathe now. So that means the baby's going to be looking at weak and short of breath. Sound real familiar? Anybody heard this before? Okay, there it is. Low energy state. You got to go look up anything. Okay, but anyway, we give them oxygen. The problem is when I give you oxygen and your alveoli collapsed, Amy, can the oxygen go across? No, you just created a diffusion problem. Anybody understand where I'm going? I'm doing step by step, so everybody following me. You just created a diffusion problem. You have a diffusion problem, Amy. What happens to the amount of oxygen reaching the blood flow, in the capillaries? Which one? Decrease. So that means the PO2 will do what? Decrease. Respiratory rate will do what? Increase. PCO2 will do what? No, you're breathing faster. Then CO2 is going to decrease. Your pH will do what? Increase. There's a blood gas for this disease. If your PO2 is low, Jesse, are your pulmonary arteries going to constrict or dilate? Oxygen dilates the pulmonary vessels. I just thought you're hypoxic. No, hypoxia would constrict them. Yeah, but the PO2 is low. Hypoxic, right. Hypoxia will cause pulmonary vasoconstriction because oxygen dilates the pulmonary vessels. Yeah, you understand? Now you got to remember back to Pasteur's law. Oxygen dilates the pulmonary vessels. So hypoxia will constrict them. Low PO2, high respiratory rate, low PCO2, high pH. You understand so far? So the PO2 is low. Pulmonary vessels are going to constrict or dilate. Constrict, therefore pulmonary pressure will do what? Increase. Pulmonary resistance will do what? Increase. Pulmonary blood flow will do what? Decrease. Pulmonary capillary wedge pressure will do what? Wedge pressure is total flow into the lungs. You just decrease the flow. All right, now you gotta be ready now. This is all stuff you've already learned. All right, so wedge pressure will decrease. S2 splitting will widen or narrow. So narrow. S2 splitting will narrow. You understand? Bailey, take over. All right. Pulmonary vessels are constricted, right? So pulmonary pressure will rise or fall. Rise. Pulmonary pressure goes up. Who's going to feel that? Right or left ventricle? Pulmonary? Okay, now don't forget all the stuff you guys have learned. All right, so it's the right side. So pulmonary will feel this, right? So is it going to affect pulmonary valve or aortic valve? Pulmonary valve is going to affect S1 or S2? S2 is going to become louder or softer? Louder. Is this a resistance or volume problem? Resistance leads to hypertrophy or dilation of that right ventricle. Hypertrophy means thick or thin walls. Thick walls means increased contractility or decreased contractility. Increased contractility, so systolic or diastolic dysfunction eventually. Diastolic, trouble filling. It's contracting hard, so it's not a systolic problem. So diastolic dysfunction. Heart failure with preserved ejection fraction or reduced ejection fraction? Preserved. Hypertrophy has plenty of contractility. Okay, but you obliterate your own ventricle. That's why you're in heart failure eventually. All right. Any questions on that? All right. So if you have less blood flow reaching your, going through your lungs, Karis, What happens to end-diastolic volume for the left ventricle? Decrease. So cardiac output, decrease stroke volume, decrease carotid stretching, decrease firing by current of 9, decrease firing by current of 10, decrease heart rate, increase norepinephrine release from the medulla, increase total peripheral resistance, increase, you're gonna veno or vasoconstrict first. Veno followed by vaso, so renal blood flow. No, renal blood flow. Decrease because you're constricted. Hopefully everybody's following this now. Okay, otherwise you got a lot of reading to do if you don't catch this pattern. All right, so renal blood flow decreases. So RAS system, renin-angiotensin aldosterone secretion. So increase sodium reabsorption. Increase total body sodium. Increase urine sodium. Decrease fractional excretion of sodium. Decrease urine potassium. Increase fractional excretion of potassium. Increase urine pH. Urine pH is going to decrease. You're secreting hydrogens into the urine. What about your serum pH? Increase the risk of precipitation. Increase risk of stone formation. Increase when sodium gets reabsorbed, it brings in 3 times as much water and dilutes your whole plasma. So when I check it, serum sodium will read what? High or low? Low chloride, low potassium, low calcium. Low, you're diluting the whole plasma. I don't know why you're hesitating. You're diluting everybody. All right, everybody understand? Now, what you thought I was talking about right now? RDS. But I wasn't talking about just RDS. You know what I was talking about? ARDS, same profile. No, that's not what I was talking about. You know what I was talking about for real? Every restricted lung disease known to man. Pick up a book, prove me wrong. I'll shake your hand. See you Monday. That's why I said, if you don't catch this pattern, now notice, what is it? It's everything you've been learning for 4 weeks. I ain't got nothing new to teach you. Well, just to let you know why it goes fast. Why? Because everything I've already taught you. All I'm gonna do is drill you on it. It's the same stuff. But that's why if you have not studied it, you'll swear I'm teaching you something new. And now you want to write down everything I say again. It's the same stuff all over again. You've heard this before. That means we can figure out the blood gas, the signs, the symptoms, the cardiac output, the electrolytes, why they got calcium underneath their skin, why they get kidney stones, why they got bad gout. I ain't got to go looking it up because I can see the connection already. And you want to see the connection, not go read about sarcoid and read about this disease and that disease, and you don't realize they're all restricted lung diseases. They're all the same. And unless you see that they're all the same, man, you're going to be panicking every time they ask you about another one. Instead of just racking up points, keep clicking the same thing. It does not change. All right, folks, see you Monday. Enjoy your weekend. Study hard, though. Study hard.
I have one quick question.
Huh? Ooh, thank you. No, only he saw it, thank goodness. All right, but anyway, what's your question? Oxygen? Yeah, you have a diffusion problem.
But okay, since we don't have surfactants, oxygen,
Now, alveoli collapse when you don't have surfactant. If the alveoli collapse, when the air comes in, the alveoli is not open, so it cannot get across to the capillaries.
okay, so it's not going in at all.
It's not going in at all. It can't get across. It's getting stuck in the bronchial, exactly.
Okay, so then why are we in the free radicals?
Because we're forcing more oxygen in there, trying to open up the alveoli. Now you got too much oxygen in here. Well, there's only a certain amount that can go across. The rest is just sitting there making free radicals. That's why you use pressure support. You're forced to try to push oxygen in there and open up the alveoli by force.
Right.
Yeah, but that means you're pushing in way more oxygen than the body would have done. And that extra oxygen will form free radicals.
Okay, because it's blowing up the little bronchioles.
It's blowing up the bronchioles, but you have more oxygen in this pocket now than you need to. because you're using it as pressure. Because it's sitting here, still waiting to diffuse across. Yeah,
Because I thought to create the free radical damage, we needed to have blood. We needed to have like.
free radical damage is just because oxygen is sitting in one spot for too long. Well, if it's sitting in the airway or alveoli for too long, it's going to form free radicals. And then some of those free radicals will go across into the bloodstream by concentration gradient alone. Yeah, it's affecting the alveolar membrane, correct? Yes, sir.
Do you happen to know anyone that's copying? I know you said you gave like
Copying.
copying.
Oh, cupping. No, not in this town. Yeah, I know, because I know a lot of Asians love the cupping. I've never experienced it because nobody does it here. Yeah, probably got to go to Chicago for that. Yeah, you don't want to go that far. Yeah, no problem.
Dr. French, I have one simple question.
All right, Ryan, go ahead.
Yeah, I just wanted to know. Well, I forgot. I'm not going to lie. What's the effects of cardiolipin again? It was 4 that you gave us, and I just can't remember.
What is cardiolipin?
Well, yeah, the effects you said that cardiolipin have in the SLE.
Oh, yeah. Remember, it can stimulate the intrinsic clotting system. It can block VWF. It can cause multiple spontaneous abortions, right?
Mhm.
And give you a false VDRL.
Okay,
yeah.
okay.
Yep.
Thank you.
All right, see you guys on Monday. Study hard.
Pray for us
Yep.
too.
Everybody's gonna make it.
So, so that's Fendi you're wearing, right?
Fendi, I have no idea. I think
That's
Versace.
that's a designer. That's Fendi.
Oh, is that Fendi?
Yeah, that's
I don't know. I
good.
just liked it. I have no idea who the hell the designer when I grab something off the shelf. I just
Oh.
like the design. So I said, hey, this go great with gray.
Okay.